We have a grand array of stellar speakers who would be joining us in this IC. We'll be changing the order a bit because there are clashing sessions going on. I would first like to call upon Dr. Shilpa Kodkani to join me. She's a co-instructor. And Dr. Suvira was here. Okay, since Dr. Mohan Rajan has not yet reached, he is finishing his IC in another room. I'll call upon Dr. Shilpa Kodkani. Now, her main topic is advantages and disadvantages of monovision for multifocality. What happens is, we have an array of multifocal lenses, we have an array of trifocal, extended depth of focus lenses. Very often we feel that is it really worth putting any of these lenses in the patient's eye, or why don't we go the traditional route of using a monovision, make one eye myopic. It used to be working so well in the past. So let's have this topic which Shilpa debates with herself, both for and against the same topic. So Dr. Shilpa Kodkani is practicing in Belgaum. She is the Chief Medical Director of Kodkani Super Speciality Eye Hospital, a very prolific cataract and refractive surgeon. And over to her.
So I'm going to talk about different roles, different goals, that is monovision. Now what exactly is monovision? It is correction of a distance vision in one eye and the near in the other, and the main aim is to correct presbyopia. Now this, over more than 3 decades, we've been treating patients with contact lenses and with refractive surgeries, and also refractive cataract surgeries for presbyopia. The concept of monovision basically is distance vision correction is done in the dominant eye, near vision correction is done in the non-dominant eye, and we hope that with neuroadaptation the patient will be happy with both distance and near, but in one eye each. Now how do we check for dominance of the eye? It is very simple, very simply done in your OPD itself, where you make the patient look through an opening like this at an object about 10 feet away, and by closing each eye, and the image which shifts is the eye which is non-dominant. That is how you know which is the dominant and which is the non-dominant eye. Now mind you, in patients with advanced cataracts, this may be difficult to do. So, but still, if the other eye is okay, it's not so advanced, you can still do this test. Now the problems that occurred with monovision were, in the past, there was a large amount of anisometropia which occurred, which was, we were aiming at 2 to 2.5 diopters of anisometropia between the dominant and the non-dominant. Stereopsis, contrast sensitivity and binocular vision were obviously compromised, and the most important thing was we were targeting distance and near, but the intermediate, which most of us need today because of our screen times, that was getting affected definitely. And so with the advent of multifocals, trifocals, and now of course EDOFs, we have been able to give intermediate vision also. But with the premium IOLs came certain problems like dysphotopsias, induced aberrations, poor night vision. Some people took time for the neuroadaptation, and there were premium IOLs. Patients are paying so much more, expectations definitely are much more. EDOFs of course do reduce these phenomena, but near vision is not usually satisfactory in them. So mini monovision is what has come in now, and today I have been doing mini monovision for some of my patients, wherein instead of that high degree of anisometropia, you reduce that anisometropia to about 1 to 1.5 diopters. So less anisometropia, faster and better is the neuroadaptation. And since you're using monofocal lenses, as we all know, it's a no-brainer that monofocal lenses are the best for best quality of vision as far as glares and halo goes. So monofocal IOLs also are not as sensitive to the residual astigmatism or to PCOs as compared to the multifocal or trifocals that we use. And they can also be used in borderline corneal and macular pathologies. Now, presbyopia correction is the balance of three interrelated factors. One is the visual acuity, depth of field, and dysphotopsias. Now, visual quality, of course, monofocal is the best. Now, as far as the depth of field and dysphotopsias go, this is where the game of aberrations comes in. Gold standard monofocal IOLs today have a negative asphericity, and that is so that you get better contrast sensitivity. But having said that, a slight positive aberration is always good for better depth of focus. And that is why for mini monovision, with a normal positive aberration on the cornea, which is usually about +2, then a zero aberration IOL will be a good option to give that better depth of focus. So if you give better depth of focus to these monovision patients, the near vision also will get corrected. So you will be able to give patients distance, intermediate, as well as near in the non-dominant eye. Because then, because of that depth of focus, the patients will see intermediate as well as near. And there have been studies done where zero aberration IOLs have been used, but for this, mind you, we need to pay attention to what the aberrations of the cornea are. There are other studies also done where Finkelman and Barrett have done a study where 96% of patients achieved 20/30 or better distance, 92% achieved J4, good stereopsis and contrast sensitivity were achieved, and in general patients were satisfied with this result. There's another interesting study that has been done by Rocha KM et al., where the aspheric IOL was used in the dominant eye and a spherical IOL was used in the non-dominant eye. And it was seen that intermediate and near vision was better in the eye with the spherical IOL as compared to the aspheric IOL. And the increased depth of field in these eyes were in the eyes which were implanted with the spherical IOLs. And it was such that, like I said earlier, dominant eye had the aspheric and the non-dominant had the spherical IOL. So what we need to aim is best spectacle-free vision is what we can promise our patients as far as monovision goes. So who are the best candidates? Those who already have some amount of anisometropia because they are already used to it, or a pre-existing monovision which they have already got in the form of contact lenses or LASIK. Highly motivated patients for the best spectacle-free vision, and a need for a more cost-effective option. And patients who are into sports definitely will benefit, because especially outdoor sports, the glare and halos are going to be more if you give a multifocal or a trifocal, of course keeping the aberrations in mind. It is definitely not indicated in patients who are drivers, who have the night vision dependency, continuous near work people, professionals like us surgeons, especially people with squints, amblyopias, or who are using prisms in their spectacles. These are definitely not good candidates for monovision. And of course, the retinal pathologies. Counseling, very, very important. Now, very often, I'm sure all of us have seen that monofocal patients whom we do monofocal IOLs in both the eyes, one eye done, it's okay. The second eye, when it is done, the next day, in spite of all the counseling that you do, they will come and say, I could see near yesterday so well before my surgery, and today I can't see near at all. This is usually the case, even if you do the best of counseling, even if you have told your counselors, you have done your counseling yourself, and these are all simple monofocal patients. They're not the high-end premium IOL patients, but still we see this. And so, we need to explain to the patients very, very carefully when we are doing the monovision. We have to explain about time for neuroadaptation. Both eyes need to be done at least one after the other, and it is always good to do one eye after the other and not simultaneously, because once you do one eye, you know exactly whether you have reached your target, and then you can tweak the other eye a little bit depending upon what your results are for the first eye. Near vision is compromised and will require some correction for fine work or print. This is something that needs to be counseled to all these monovision patients. So what does blended vision? Blended vision is basically we are keeping the patient targeting -1. We are achieving good distance and intermediate, and of course we are able to give near vision with that extended depth of focus that we can give. But it should not be promised. Never over-promise. Near vision correction will be required. This is what we tell our patients. If they don't require it, we are very happy, so are they. And what we realize is the same counseling is being done for our EDOF patients. So this is what exactly we tell our EDOF patients. So if we compare, it is the EDOF versus monovision that we would normally be looking at. What is prudent is whether we should be doing an EDOF or a mini monovision in these patients. The criteria, as far as I am concerned, I do it according to affordability and what the patient wants. If the patient is very clear that they want a spectacle-free vision, they cannot afford anything like premium IOLs, then I do mini monovision. And in my hands, the happiest mini monovision patients are the Indian IOL groups. Now, what could be the reason? Is it less expectations? Is it because the Indian options we are using spherical IOLs? Are the expectations more with those who pay more? And of course, today it's not only paying patients. Today, everyone is demanding, and rightly so. The advantages of monovision patients is that they can see distance intermediate, and also in a lot of our patients we see that we can give near vision provided we are taking care of the aberrations. Patients are less dependent on glasses. Night vision of course is better. Contrast sensitivity is better with the aspheric in the dominant eye. The disadvantages, again, like we said, stereopsis to some extent. One eye is used at one time, and neural adaptation can take a little longer in some patients. And of course, we always, in spite of everything, can have some unhappy patients. Now, the take-home messages: mini monovision should be an option in every ophthalmologist's armamentarium. We have to look into the spherical aberrations and the higher order aberrations before planning anything. A mix and match of aspheric and spherical IOLs is always better, and it is a more cost-effective way, and it can be one of your strategies, especially when in your Indian IOL packages. And of course, we need to keep in mind when not to do a monovision. And our strive for high quality and high level of satisfaction continues. Thank you so much.
Thank you, Dr. Shilpa. I think we'll take questions at the end. So I now call upon our next speaker, a speaker who doesn't need any introduction. He is probably the most famous speaker in any of the Indian and international ophthalmic forums. He's been the winner of many, I don't even know how many OPLs. Dr. Mohan Rajan from Rajan Eye Institute, Chennai, surgeon par excellence. And he will be speaking today on whether it's prudent to put in a multifocal IOL in a patient with a mature cataract. So we have this scenario with mature cataracts, patients coming in, we don't know what is the condition of the retina and whether it's really prudent to put in a multifocal IOL. So his topic today is, should I dive in blind? Multifocal IOL in cataracts, pros and cons.
No matter. एक मिनट है. Okay. Yeah. Thank you, Nitin, for this wonderful opportunity. I think it's a beautiful topic what you have chosen, the big fight as well as this thing. It's a very important dilemma I think all of us are facing. Should I dive in the blind, multifocals in mature cataracts? These are my financial interests. See, as you know, these white cataracts, you can term it, you categorize into 3 categories. Type 1 with the intermittent white cataracts, the mature white cataracts, and the hypermature white cataracts. Why I am telling this? Because in the first category, the interlenticular pressure is very high, and most likely you can get an Argentina flag sign. Okay, and if you get an Argentina flag sign, obviously you cannot put a multifocal lens. Am I right or not? So that is the reason why I want to categorize that. So initially on the slit lamp you find out. In my opinion, for whatever technology is available today and whatever techniques we have got today, I don't differentiate between an immature and mature cataract as far as a multifocal. If the patient wants multifocal, if the patient, the other eye, everything is normal, then I would prefer a multifocal lens. And I have very good reasons to say that. Okay, what are the things you should check for before you put a multifocal lens? For that matter, any check the pupils. Make sure that this patient has got fairly, because many times they have mature cataract, they are not very sure when they lost the vision in that eye. So they may have an underlying optic nerve or a retina problem. Check the pupils, get the rexis right. 100% you have to get the rexis right. Okay, if you want a multifocal lens, get the biometry right, which is very, very important, because in multifocal lenses, you need to get the bullseye consistently. How do you get the bullseye? If you are an optical biometer. If you have an optical biometer, okay, the optical biometer, unless of course you have IOL Master 700, it can penetrate near total cataract, but not total cataracts, white cataracts like this. You need to have probably depend on your contact A-scan method or immersion. Immersion is probably better, and get the biometry right, because in a unifocal you can go this way or that way, but in a multifocal you have to be there right, because the patient is paying for it, and that's the reason why. Make sure the macula is fine, and consistent surgery is very important. You need to make sure your surgery is there and day one the cornea is clear. Look for amblyopia, look for anisometropia. Again, we have seen many patients, multifocal mature cataracts in one eye, and that eye will have high myopia. Please understand, this eye will have high myopia, the other eye will have hemetropia, this eye will have 10 diopter, the other eye will have 24 diopter, and you know, that is a red flag sign for you. Okay, if you put a multifocal lens, probably the patient will become probably had amblyopia because there is anisometropia, and probably the patient will become very unhappy postoperatively. Exotropia also look for it as well. Prerequisites again: healthy cornea, healthy macula, accurate biometry, good rexis, no intraoperative complications are very, very necessary. Thank you very much. And Pearl 1. Okay, the Pearl 1 is a constant A-scan contact method. Okay, what are the fallacies of A-scan? These are cons. Okay, the A-scan is not a very reliable method. I am talking about the contact A-scan. It's not a very, because it varies from one optometrist to another, or inter-observer. Variance will be there, and the variability is, for example, if you press the cornea, what will happen if you press the cornea? You will get less axial length and more IOL power. Okay, instead of 20 diopter, you will put 23 diopter. In a monofocal lens, you can probably manage and talk to the patient, but in a multifocal lens, he will cut your head. Okay, he will decapitate you. So that is the reason why I think it's important that you need to be there. A-scan. Probably if you have access to immersion scan, immersion scan is probably a good way to go if you have the immersion scan with you, because it is almost equivalent to an optical biometry. But if you have access to the optical biometry like what we have, like IOL Master 700, then this actually penetrates even a very, because it works in a totally different technology, swept source technology, and that is the reason why it's able to get a 3-dimensional view of the eye. And this IOL Master 700 is fantastic if you have access to it. Probably even posterior polar cataracts, or almost, you can see this is almost a total cataract. If it's a very total cataract, very wide cataract, very difficult. Near total cataracts, you can still penetrate. The advantages of the IOL Master is really wonderful, and it gives you the lot of data for you, the corneal thickness, the anterior chamber, the lens thickness, the pupil diameter, everything, the wide to wide, everything is available in the IOL Master. Again, if you are not able to get any of these, please 100% you have to do a B scan. B scan has to be done for all mature cataracts. Otherwise, you will end up in a medico-legal problem. Please understand, you cannot say that I don't have a B scan. Okay, you should have a B scan for all the mature cataracts. But the B scan can give you a gross idea of the retina. It will give you a gross idea of the retina, but it will not tell you what is the status of the macula, what is the status of the, whether there's any ERM or anything. For example, this patient had a BRVO and preoperatively, and this patient didn't have an RAPD, everything was normal, the other eye was normal, this patient had a BRVO and macular edema as well, and postoperatively, after putting a multifocal, we burnt our fingers, and this is, I think, probably there's thing on a VMT and a CME as well. So Pearl 2 is preoperative protocols. I give for all these, especially type 1 cataracts, I give IV mannitol, oral acetazolamide, peribulbar block, super pinky, good hypotony to make sure. And Pearl 3, use high molecular weight viscoelastics like a soft shell technique. Viscoelastics are available. It's available cheaply with all the Indian companies as well. Soft shell technique wherein you put dispersive and then underneath the dispersive you put a cohesive viscoelastic and makes the life easy for you. You can see here how I'm putting a soft shell technique, making this rhexis very easy, because these mature cataracts, the rhexis can run away, especially the type 1 mature cataract. You have to be very careful. So type 2 also it's possible, but type 3 is hypermature sclerotic. The rhexis very rarely runs away, but you can have an Argentina flag sign. You can see that soft shell technique is one of the important things. So capsular rhexis, use Trypan blue under eye. Aim for small rhexis, double rhexis. You can use a 26 gauge, 30 gauge, 27 gauge. So this is one thing which I've done a lot of work on this capsular rhexis. You must have all seen my puncturexis technique. See, there is a pressure underneath the anterior capsule. The nucleus is bulky, and there is a pressure in front of the posterior capsule also, and the positive vitreous pressure. There are 4 components. Okay, if you put a 26 gauge needle or a 27 gauge needle into the front compartment, it takes care only of the front compartment. The other 3 compartments are still there. So the other 3 components are still there. So if you put for example, if you touch this, for example, this Argentina flag sign, and as soon as you touch it, it goes to the periphery. Okay. This is very dangerous. You can't even put a multifocal lens. Sometimes you can't even put a lens because the nucleus can go, it can wrap around, go around the zonules into the posterior capsule as well. You can lose the nucleus into this thing. You can use a 27 gauge needle. You can see here how I'm using a 27 gauge needle in this particular case and aspirating the front compartment. The front, it works in about 50 to 60% of the case. You can see how I'm doing that. I'm aspirating and decompressing our intralentricular pressure by means of a 27 gauge needle, and then going ahead with the rhexis. You can see here in the usual manner. It works many of the times, or you have access to Zepto is probably one of the ways by which you can get a consistent rhexis even in a mature white cataract. But if you have access to the femto, it's probably one of the best methods which I have access in all the mature cataracts. Why I am putting multifocal lenses, because I'm having access to the femtorhexis, which makes life easy. Only thing is, you look for skip areas in femtorhexis, and many times it may not be a free floating thing. In a puncturexis, what you do is go underneath, go into the anterior capsule straight away, as if you are directing the phaco probe, bevel down. You don't use a Kelman tip or an angle tip, use a straight tip. You can see how I'm doing the punch there. Punch not only the anterior capsule, you can see I'm going all the way down. I'm having a continuous phaco power of about 50-60%, and the burst of phaco not only punches the anterior capsule, it also debulks emulsifies the nucleus and debulks the nucleus and pushes the nucleus back. It takes care of all the 4 components which I am mentioning about. Again, you can see these are the parameters I use on a sterilized mission. Just use high vacuum and a good phaco power of about 40-50% punch as if you are going into the anterior vitreous. Don't go tangentially, go vertically down. Then you can see here how I am doing the puncturexis again. Okay. So Pearl 5 is vertical chop technique. What I am trying to vertical chop technique is, the vertical chop technique is probably the best method by which you can take care of this, because many of these white cataracts are very hard cataracts as well. Use a sharp chopper. I have devised a chopper which is available with Appaswamy, and because you see a sharp chopper, how it opens up the posterior nuclear plate and make the cataract into smaller pieces. Be careful in doing a hydrodissection. White cataract, sometimes it can be a very soft cat. Be careful in trenching. Sometimes you can vacuum, can open up the posterior capsule as well. If you have small pupil, always use iris hooks or a Mulligan ring or whatever it is right in the beginning of the surgery, and this thing. So this is just to show you what are the mistakes we have done. This patient had a diabetic maculopathy. Okay, when you have diabetic maculopathy in one eye, please understand that diabetic retinopathy is a bilateral disease. Okay. This patient had diabetic retinopathy, maculopathy in one eye. So other eye we put a multifocal lens. We burnt our fingers. You can see we did a B scan. B scan will not reveal a maculopathy. So again, so this is the patient. Again, the OD right eye. You can see that after the surgery, we found out that this patient has got diabetic retinopathy as well. Again, you can see another patient with the ERM. ERM also is very difficult to pick it up on a B scan in a mature cataract. So this patient had a ERM. The patient was very unhappy with the multifocal lens. See that these are the cons of this the particular. So if the patient has earlier come to you a few years back and then come with a mature cataract, if you have know the history of the patient, it's probably if you have a patient, this patient had a macular hole, and this patient had a BR view with vitreous hemorrhage. Sometimes a fresh vitreous hemorrhage you will not be able to pick it up on the B scan. But the take-home message is, many of the multifocals, the mature cataracts, you can go ahead, you can see the synergy lenses which I'm using now very frequently for all these patients, and the long-term follow-up of these patients with the mature cataract as well. The take-home message is accurate biometry, ensure good to hypertony, high molecular weight, viscoelastic, capsulorhexis, different ways of which you can skin the cat, and vertical chop technique, making sure that you are doing well. End of the day, you should know what the patient is in for. The patient's expectations are very high when they have a multifocal lens. You have to make sure, always go by the fellow eye. If the fellow eye is good, probably most of the times you are right in this, putting a multifocal in the mature cataract. Thank you very much for the wonderful opportunity.
Thank you, Mohan. That was lovely. A very, very good insight into the topic. I now call upon Dr. Suvira Jain. Suvira heads the phaco department in Haji Bachioli Hospital in Bombay. She is handheld and taught phaco to quite a few people in this conference. 800. And she's had at least 800 fellows under her who undergone the phaco training from Suvira. So now in our practice, very often we have a scenario where a patient has already got one eye operated with a monofocal IOL, and having heard about multifocal IOLs, about independence from glasses from others, some of their colleagues, some of their friends, they want to know, they come to you and ask you for a multifocal IOL in the second eye. So Suvira is going to tell us what to do whenever these patients, the two eyes are not in sync. That is, a patient with a monofocal IOL desires a multifocal IOL in the fellow eye. Will you do it or will you refuse? Over to you, Suvira.
So, are multifocal IOLs a viable option for a patient who's had a monofocal IOL implant in the first eye? So here's the scenario. The patient has had a monofocal IOL implant done a few months, maybe a few years ago. He's dissatisfied with his near vision. He has come to you with an operable cataract, and now he's saying, Doc, can you put an IOL in my other eye that will enable me see better for near? So the question asked to me is, would I consider implanting a multifocal IOL in this second eye or not? And my answer is, yes, I would. Having decided that I'm going to go ahead and do it, these are the various things that I need to consider. First, remember that there's very little literature talking about the quality of vision, the binocular quality of vision with a patient with a monofocal in one eye and a multifocal in the other eye. Having decided that I can go ahead with it, These are all the points that I take into consideration. The first and the most important is a thorough evaluation of the quality of vision in the patient's first operated monofocal eye. So what do I need to look at? I need to look at what is his uncorrected visual acuity for distance, what is the refractive correction he needs for distance in that eye, what does he think is his quality of vision overall, and which of his visual needs are left unfulfilled. We are sure that he's come to you, he can't see for near, but what of his even distant visual needs may or may not be completely met. And therefore, we have to now look at which are the options of presbyopia correcting lenses that we can consider in this patient. Largely, they are divided into categories. It could be either the multifocal IOLs or the extended depth of focus IOLs. Now, to me, the decision largely rests on what is the refractive status of the patient's first eye. Is the patient emetropic, or does he have a residual refractive error? Let's take the first consideration. If the patient is emetropic for distance, which means he's 20/20 happy for distance, which means all his distance visual needs are met. So I no longer have to worry too much about getting his 6/6 in the other eye. I don't have to at least be paranoid about it. He's happy with the 6/6 in the other eye. So now I would choose a lens that would enable me get him an N6 for near. Because people who pay for multifocality are very likely to not be able to accept suboptimal near vision. So I would choose a lens that would enable him get a N6 in my hands, right? So now, again, we go through the two options. Why would multifocal IOL possibly be my first choice? Because with a multifocal IOL, if assuming you get your biometry right with your experience and expertise and getting it done at various places, if you can get your biometry right, I'm going to be able to give him a 6/6 for distance and a N6 for near. There's no compromise in his distance that I need to do to play around with his near vision. That's where a multifocal lens scores. But the demerits are, of course, as Warren Hill says, we buy the depth of focus by paying with the currency of contrast. The fact that he's going to have slightly reduced brightness overall, that waxy vision, which is here to stay. And of course, because of the diffractive rings, there would be some amount of photic phenomena which would, subject to neuroadaptation, wane over time. Again, when we look at the multifocals today, I don't know whether how many of us still consider just the bifocal lenses. With the trifocals coming into the market, by being able to provide an intermediate focus for intermediate vision, you know, we get that constant range of vision, which is very good because we do know that almost 80 to 85% of all our near activities take place at 60 centimeters. So a bifocal lens which corrects you for distance and one point at 33/40 for near, I think is no longer meets the standard of near and intermediate vision that most of us want, whether it's signing checks, counting money, searching for keys, opening a lock, looking at a chime aid, for me, looking whether it's rye or whether it's tea leaves. All of that at 60 centimeters is very, very important, seeing people seeing their own food. So I think if we must be able to provide that intermediate range of vision for all our patients, and that's where I think trifocals score, but it also has a better light energy distribution, therefore the contrast is also less. Now, we're still talking about the same patient, the patient who's got 20/20 for distance. Now, the other equally interesting option is the EDOF lens, so the extended depth of focus lens. But I'll talk about them a little later, the specific ones. But with these lenses, the biggest advantage is that neuroadaptation, photic phenomena may not be an issue. The drop in contrast won't be an issue because there are no rings here. And with a little bit of micromonovision, that means if you aim for like a -0.5 or a -0.75, a N6 is achievable, which is what he came to you for. So why this would also be an option would be because he's 20/20 in the other eye. So being 20/20 in the other eye, even if you leave him with a 6/9 or a 6/9 part, 20/40 part in this eye with the micromonovision, you're going to be able to achieve your N6, generally speaking. My choice, personally, I would still be brave enough and I would put in a trifocal because I would want to give him 20/20 and an N6. However, if there's a patient who is very fussy, comes with 10 pairs of glasses, says what neuroadaptation, refuses to think that rings are an option, needs a lot of night driving, very, very fussy and anxious, then in that patient, despite a 20/20 in the other eye, my first choice only then would possibly be an EDOF lens. Now we come to the scenario number 2. This is the only of the 2 scenarios. Now the patient has got a residual refractive error. I feel that when a patient has got a residual refractive error, again, there are 2 things to consider. There are a lot of people with 6/9, 6/12 vision who are happy. Matlab, their visual needs are met. Say, doc, I can see everything I do. They can even drive, they can see people far away, they can look at hoardings, they can watch the television well. They don't have any issues. So I make it a point to, after examining and coming to the point that even that he does have a residual refractive error, which of his needs are unmet for distance? The second scenario would be somebody who's got, again, say a 6/9, 6/12 and requires like a -1 or a +1 or any kind of refractive error, but without wearing those glasses, say he's a -1. Like my cousin, for instance, he can't see hoardings. There are people who can't see the Netflix print on the television. So their distance visual need is not met. This is the second of the second scenario. He's not 20/20 for distance. He needs glasses for some work. Though he's come to you only seeking spectacle independence for near, you're going, so what would I do in a case like this? My first choice here would be a trifocal lens. Whether or not a patient complains of distant symptoms, distant visual symptoms, if I find a suboptimal vision, definitely if he's symptomatic for distance or requires glasses for some activities, I would aim for a trifocal IOL because I would want to take care of the, the unmet visual needs for distance, which might be there, which is not too much of a problem to him, and give him an N6 for near. I'd be able to give him both if I thought of a trifocal lens. My second choice would be an extended depth of focus IOL here, but in a case like this, to achieve an N6, almost always I'd have to leave the patient myopic by -0.5 or -0.75. Now that may not necessarily be bad, especially if it's a patient who is quite happy for his distance vision, even with a 6/12 or 6/9. Leaving him myopic by 0.5 or 0.75, I'd still give him a 6/9, 6/9 part for distance. Anyway, I know he's quite happy with the other eye with this vision. And then I might consider giving him EDOF lens to give him an N6, but I would work him up to try and aim for an N6 for near. Perhaps in a patient like this, I might consider discussing laser vision correction at a later date, because suppose eventually what I get leaves him still not 100% for distance and for some reason dissatisfied, I might want to have just spoken about it later. And definitely I'd think of EDOF for a patient, even with suboptimal distance vision, if he's the typical fussy type A, refusing to accept that neuroadaptation may take time, or someone who may need to drive at night. I think our choice of lenses, correct me if I'm wrong, of course all the companies talk to us about all the different lenses, but I think we tend to use lenses which we get the best results. Okay, so when we are thinking of a multifocal or trifocal lens, you could have the Zeiss trifocal, which claims to have excellent optical efficiency, the third focal point we spoke about, precision astigmatic control. You could go with the Panoptics, which claims the only US FDA approved lens, which claims to be the only lens that gives you the intermediate focus at 60. But I think eventually we choose a lens wherein we get, so my personal choice tends to be, I tend to go with a Zeiss trifocal because the way I work out my biometry, discuss with the company person, and you should discuss with them. They know things that we don't. They have more experience with many other users. I'm able to hit my 6/6 N6 target. And that doesn't necessitate that I need to be a great surgeon. I need to be a great person, great doctor who can work up patients well to aim to get the right result. There are a lot of lenses now available which are true EDOF lenses. But with all of them, there is that compromise. You're going to get your N6 by leaving the patient -0.5 or -0.75. Symphony, the oldest lens, by virtue of the J&J material, has got a lot of advantages. But with its edgelet design, gives you an elongated focus. Symphony people say, you'll get an N8 at 40, which I think is pretty good. At the most, he may require glasses to read, very fine print. There's the Alcon Vivity, a lot more expensive. It's got a dome-shaped elevated plateau in the central 2.2 millimeters, 1 micron high, which actually stretches the wavefront, giving you a constant extended focus. They also claim to give you an N8 at 40. And then there is the Miniwell. Miniwell Now, what the mini-well lens does is it's converted into 3 zones: the central 2 millimeters, 2 to 3 millimeters, and beyond. Now, by inducing spherical aberrations in the center of a -2 millimeters in the center, of a +2 in the mid-periphery, by inducing different amounts of spherical aberration, causes a stretch in the wavefront and thereby gives you that intermediate range of vision. So finally, now that you've decided you're going to do it, so just quickly touch upon the 3 important points. One is your accuracy of data collection. That is by far the most important thing, irrespective of any lens you want to do. Take more than 1 reading. IOL power calculation, optical biometry is the gold standard. Aim for closest to emetropia. Always, when it comes to K and axial length and IOL power calculation, have at least 2 or 3 sets of data. Go with Warren Hill's triangle of agreement, wherein you look at data in at least 3 instruments, compare, look for a concordance between 2, and then choose. And when in doubt, axial length difference of more than 2 millimeters, silicon oil-filled eye, you've got a suboptimal result, or a post-refractive, you do a second biometry. We are in Bombay, we can always outsource it to Dr. Deepak Bhatt to get the second one. If you've got astigmatism, do a topography to rule out non-orthogonal astigmatism, and choose one of the lenses in this platform which has a toric offering, and most of them do. Counseling, I think the first thing we need to tell all patients is the fact that the only lens that can give you near normal vision is the normal human crystalline lens. Anything else, and everything else that we implant in the eye, there is going to be some element of compromise. Let them understand how the lenses work, speak in their language, vernacular, with all the decision makers, slowly, quietly, and give them the time to go back and process all the information. When you talk about the lenses, tell them that there's a possibility of drop in contrast. You may need glasses, and then the fact that he may see glare and halos, which may take some time. Also, let him know that he'll have stereopsis for distance, but his near vision needs should be fulfilled by only the second eye that you're going to operate. Also, let them know that despite the best of efforts and best of evaluation, there is a possibility that he may require glasses for either activity, and that's the other thing. Discuss laser vision correction if you think it might ever be required. And I also need to tell them at the end that should things go wrong, that sometimes we may not be able to implant a multifocal lens in the eye. And my final slide is, how do you achieve surgical finesse? It's important that we try and put in a multifocal in this eye, because this is what you've kind of told him you're going to do. Be extremely meticulous in your wound construction. Make sure you have a nice centered rhexis, 5.5 millimeter, that gives you a 360-degree edge. Make sure that you leave your corneas nice and gentle and your endothelium undamaged by minimizing the energy delivery by doing power modulation. Obviously, you want to avoid tears in the CCC because you don't want post-operative decentration. Obviously, no tears in the PC, because that would just take away the possibility of putting it in. Thorough cortical wash. If you've got a small pupil, use pupil expanders. A careful IOL implantation completely in the capsular bag. And my last point is that should you have a subluxated bag, a tear in the rhexis, defer the multifocal IOL, even if you promise the patient the same. Thanks, everyone.
Thank you, Suvira.
I have one question, Suvira. It's a fantastic talk. I just have one question. One is that if this patient has come to you asking for a multifocal when the other eye has been implanted with a monofocal, am I right?
Yeah.
So what is your numbers? How many numbers do you have to say that a monofocal will mix well with a multifocal in the other eye?
Well, maybe about 10.
10.
But I've spoken to a lot of people who've been doing it in other cities here, and they're extremely happy.
So
they say patients adjust really well.
There's no compromise on vision. Their quality of vision is good when you have combined a monofocal with a multifocal.
Yes, so when I've spoken to my colleagues and my own patients about it, I generally choose the right patients, Like someone like me, even if I had a monofocal in one eye, if I could get rid of glasses for reading, I would take the compromise that came with it.
The second question is, have you ever explanted a monofocal to put a multifocal in the other eye?
No, I haven't, but I've put on an add-on multifocal.
Okay.
I haven't explanted one.
Okay. Thank you. Fantastic talk.
Are there any more questions?
I think we'll take the questions later. Thank you, Suvira. For excellence, and he has been on the podium for n number of refractive and corneal, refractive and cataract symposiums. Over to you, Sandeep.
Yeah, thank you, Nitin, for those kind words, and thank you for this humbling opportunity. When you stop seeing those little drops coming in, you know that you need glasses. And when that comes in, comes that little, I have really no financial interest in any of the technologies or products mentioned over here. So this is your dilemma. You have a patient in front of you, an early presbyo, just not willing to accept glasses. He's just 40 years old. For the first time, he's realized he can't read his newspaper in the morning, and he's coming and bombarding you. He's just there. And you are also in a dilemma because none of the technologies that you have on hand are foolproof. None are permanent, so you don't know what to do. But yet, basically, you need to do something. Now, the first thing is some basic concepts here. We all know that accommodation from the lens is an active dynamic process. It depends on the elastic properties of the lens, which has a high depth of focus. On the other hand, when you're trying to look at the cornea, this is a tissue which is more static, and it has a low depth of focus. So in lens-based options, what you're doing is basically you're sacrificing the natural accommodation of the eye for a pseudo accommodation, which is certainly not as good as the natural accommodation. Remember, at 40 and 41, they may have lost a little bit of accommodation, but they still have some accommodation left. Okay? So here basically you're putting a lens which is either going to split light or is going to enlarge the depth of focus. And in corneal-based laser procedures, you're going to play around with the spherical aberration of the cornea so as to increase the focal amplitude. And so these are various options available to you. And today we are going to stick to basically the options of changing the lens or changing the depth of focus, which is basically a Presby LASIK. Now in pre-lex surgery, what can you offer this 40, 45-year-old? Can you go in for monovision with monofocal IOLs in which the dominant eye is corrected for distance and the non-dominant for near? And we're going to talk about results later. The diffractive IOLs or the EDOF IOLs, and monovision with monofocals. That means you put one eye, you correct him for distance, and you put a monofocal in the other eye, and you correct him for near. Or you may even slightly modify and reduce the amount of disparity by increasing the myopia to about minus 1.5 diopters. However, the biggest problem with monovision in cases of monofocal IOLs, it is difficult to predict where the monovision will work. And hence, I would say to all these patients who are in the 40-45 age group, and if you're planning monovision either by IOL or by laser, the first most important thing is to give him a monovision contact lens trial. Not spectacle vision, but contact lens trial to know whether monovision will work. Because the biggest problem you have in your life is if monovision doesn't work this way or that way, that is out of the way. And remember, it's a contact lens trial. Okay? And of course, you have to explain to them that stereopsis might be lost if your difference increases by more than 1.5. Some people say, other eye, I have to read, you know, and then you have to tell them that if you're trying monovision, you're going to lose your 3-depth focus. Trifocals, all are modern, and I don't want to go in details of this slide. We all know that they have issues with loss of contrast, issues with glare, and halos during night driving. And of course, the biggest challenge in this 40 to 45 age group is that the refraction is going to change over time. Now, all of us know that the cornea keeps on changing very slowly, and right up till the age of 50, though the books say 45, there is some shift in the astigmatism that occurs at the level of the cornea. And over a period of time later on, there is going to be, as your posterior corneal astigmatism increases, there's going to be a drift towards more against the rule astigmatism. So are you going to load in with a lens at this time? And what about the changes that will come later? Will he be prepared to wear glasses then, or he'll come to you for another procedure? The EDOF IOLs, well, whatever type you get an elongated depth of focus. You have better contrast, less glare and halos as compared to the trifocal. However, the near vision in all these cases is often compromised as the addition is low. So what is my indication for prelex in the 40 to 45-year-olds is individuals with small or early lenticular changes. If I find even if there is a small change in the lens, you know, there is a little bit of cataract, I would put in and go in for a lens-based procedure as compared to changing something on the cornea. And of course, hyperopes. If in all hyperopes, if they have a shallow anterior chamber and there is a likelihood of an occludable angle and they are asking for these things, and if they really insist on these things, I would definitely do a lens-based procedure. On the other hand, let's see what corneal refractive surgery has to offer, because there's a lot of work being generated in this direction. We all heard of central Presby LASIK, in which the central zone in the non-dominant eye can be corrected for near, okay? So you have this zone which is correct, and this is available on all laser platforms, and a small transition zone, and then the peripheral is corrected for, for distance, and beyond that, of course, is the untreated zone. And then you have another thing which comes from Technolas. This is called a supracore. It creates a hyperpositive area in the central 3 mm zone, giving an addition of approximately 2 diopters. And it can be used either symmetrically or asymmetrically. The Presby max comes from Schwind. Basically, here you're making the cornea genuinely multifocal. There are two kind of hyperpolate surfaces there. One to correct your distance, one for intermediate, and one for near. And it's probably the only technology with published results in cases of emetropes and myopes. Most of the other technology of Presby LASIK have been published are in hyperopes, and they are, of course, very good results over there. Now, the Nidec people thought that in all these earlier technologies, since the central zone was corrected for near, it always led to a compromise in the distance vision. So what they thought very smartly is that let's keep the distance vision as the central vision as corrected for distance, and the peripheral zone in the cornea, let's correct it for near. Now, there is a problem here because most pupils are not large enough to accommodate so many zones. Again, in bright light, you are constricted, and when you have bright light, you have meiosis, and you can't read. And the basic thing is that if you were to try and do this in a myope, you tend to eat up a lot of tissue. So that's the problem with peripheral LASIK. Now let's look at a technology which basically believes in altering only the spherical aberrations. And this comes from Carl Zeiss. They have the Press Beyond, which as we know is laser blended vision. The non-dominant eye is made slightly myopic, about -1.5 diopters. And there is an area, a zone of intermediate vision which crosses in both the eyes. Means there is a blended zone, as you can see in the center, which overlaps the two eyes. So that gives you a full functional range of vision. And this can be attempted in emetropic, myopic, as well as hyperopic eyes. Now, unfortunately, I don't own a Technolas. I don't own a supracore. I don't own a Schwind. Okay, but what do I have? And what would I do if this patient comes to me? And this is what I tend to do. This is the custom tube. Now, remember this diagram very well. Basically, in the center, you have the pupil outlined by the brown ring. So there are two zones in that. One is the paraaxial zone of 1.5 millimeters, also the one which is most referred to in the Gaussian profile. So when you put this patient on an autorefractometer, when you put him in an IOL master, the refraction that you get is always from the central 1.5 millimeter zone. And in the periphery is the paracentral zone. Now look at this a little more closely. This is an OPD, optical path deviation map from the Nidec machine, the OPD3. And you can see that in the center, you have an area which is emetropic. And as you go into the periphery, you have a slightly hyperopic zone and a slightly myopic zone here. So as you go into the periphery, spherical aberrations come here. All the pluses denote hyperopia, okay? But remember, this is not a topography map, though it looks like a topography. It's a wavefront map. So where is the wavefront going to come from? It's going to come from the aberrations in the cornea and the crystalline lens. And it's reflected only within the pupil. Look at a case of a myopia, a -1.5 with -1. So there are minuses all around, suggesting that this is the steeper meridian and this is the flatter meridian, exactly opposite of what we see on our traditional topographers. And this is what happens when you correct his best, you put in a spectacle and you make this patient, and you put this patient on the Nidec machine. You can see that in the periphery, -140, -173. So some amount of positive spherical aberrations always coming once you move even slightly away from the center of the pupil, once you go away from the 1.5 zone. And why is that? That happens because as you go towards the periphery, the angle of incidence increases. As the angle of incidence increases, the angle of refraction increases. Therefore, those rays don't focus on the retina. They come a little in front, and that's the basis of your spherical aberration. Now, here you have a case where this patient, as you can see, is getting early nuclear sclerosis. Because this early nuclear sclerosis, he has this -269, -317 and all in the center. And suddenly this patient who was always using reading glasses one day comes and says that I can't read anymore. And surprisingly, when you put this patient on the chart, this patient is still reading 6/9 and J2. That is because in the periphery, he has reduced spherical aberrations in very early nuclear sclerosis. And this is the basis and the principle on which we are going to base this. So you have, let's come back to this figure. So if we can increase the hyperopia over here and give this person a little bit of a negative spherical aberration and give him reading vision and keep the paracentral zone for distance, I think you have a winner on hand. So what is the principle of the custom cube? It's to make the central 1.5 millimeter zone hyperprolate to produce a myopic shift, and the spherical aberration should be changed by a value of -0.4 so that you can get a reading correction. So this translates to a delta Q, that means a change in the corneal asphericity. What is the Q value? Is the aspheric quotient. So if you can change the aspheric quotient by about a -0.6, you are able to achieve the hyperprolate only in the central 1.5 zone located on the visual axis. The paracentral zone can then be maintained to achieve sufficient distant correction so that in cases of hyperopia, it would retain a sufficient negative spherical aberration. And this leads to better binocular vision. And this shows that at the -0.4 spherical aberration correct, you need to reduce about a -0.6. Now let me give you a clinical example. So this is a case where a patient is an early press bio. He has +175 in the eye, which is dominant, and 2 in the other eye. His asphericity is about -0.2 in both eyes. So how do you plan the correction? You target emetropia in the dominant eye. That means you correct as 1 + 1.5. And you target a -2.5 in the non-dominant eye so that you give reading vision. And the -point Q, you change to a -0.8 because you have to change the delta Q by -0.6. That's all you need to feed into your laser machine. And this can be done on any laser platform, which allows you to customize the Q value in your patient. So this is what you plan, and this is what you get. So what you do is in the dominant eye, you give him a good emetropia. His target refraction is 0, Q -point Q, and here target refraction -2.5 and -8. So here he gets a little depth of focus in that eye without compromising the distance vision. And these are the profiles of ablation for the non-dominant and the dominant eye. And you can see the results that in the dominant eye, you have a little area of hyperprolateness in the center of the cornea, which corrects his +2.5, and a little more bump in the non-dominant eye, which corrects his near vision profile as well. And there are enough results published in the literature which shows that binocular distance as well as binocular uncorrected near vision are very satisfactory. So in my opinion, what are the indications for Press B LASIK in the 40-45-year-olds? They should be highly motivated patients with clear lenses. They should understand the limitations of the procedure. For emetropia especially, you've got to be very careful. They have to understand that they are going to lose some amount of distance vision. For myopes in whom intraocular procedure are risky, this is the procedure of choice. And suppose you have a young pseudophakic with a monofocal eye. This is something which Sugira was alluding to. If after getting the trifocal or the EDOF in this eye, he wants to improve the depth of focus in this eye where you put a monofocal, you can do this procedure. So contraindications are people with thin corneas or possible keratoconus, previous incisional surgery, or other ocular comorbidities. And what are the results of the Press B LASIK? They are most suited for young hyperopes. Don't hesitate, this will work very well. And if you can stretch that age group 40 to 50, Nitin, this is something which can definitely work. And central Press B LASIK is preferable to peripheral Press B LASIK. Both are, of course, associated with some loss of vision if you have the entire pupillary zone, but you can think of custom Q to avoid that thing. And basically, if you're looking at myopes and emetropes, the preferred thing would be a Press B Max hybrid. This is dependent on the results that I'm seeing in the literature, Press Beyond and Monovision LASIK. And for hyperopes, you should go for supracore, Press B Max symmetric, custom Q, and Press Beyond. So what is finally my personal preference for this age group? Hyperopes, custom Q, as I mentioned so elaborately on the Wavelight EX500, and prelex in very few select cases. I don't like to do prelex in this 40 to 45 age group. They still have accommodation, they still have good contrast, they still have a cornea that is evolving, and there is a long way to go at 40. I mean, most people live till 80 now, so I would like to defer that for some age, some point of time. Maybe after 48, 50, I might go in for that. For myopes, I do a monovision LASIK, which seems to work well, and all of us have sufficient experience. As I said, remember the contact lens trial before you do the procedure. And prelex in a myope, never. I don't think so. It's too risky to go in. And if this fellow develops a PCO and you're going to yag him and you're going to open a whole, whole box of problems for the posterior segment. And when a hemetrope comes to me and he asks me for this procedure, I arch my eyebrows, I give a wide smile. Are you serious? That's what I'd ask. Thank you.
Thank you, Sandeep. That was very, very educative.
Excellent. You go back to your, you're going back to
Yeah.
your,
Today in our armamentarium, we have quite a few new instruments, high-tech instruments which are available.
yeah, no problem.
And very often the question which comes to our mind is, are these real tech gizmos? Are these real something which the trade is pushing us into? Or do they have any great advantage? There is one such tech gizmo which I would like to talk about today, is the image-guided surgery in cataract surgery. So I would be speaking on the image-guided surgery. Is it a hype or is it really worth the hype? Get your laptop. It's already loaded on your laptop.
Yeah. Introduce Nitin. Nitin. Yes. Hi everybody. We have the course master here, Dr. Nitin Balakrishnan. He is not only a wonderful surgeon, but I think he has a very scientific mind. That's why he takes the most complex talks every time. So let's look at what he has to say about image-guided cataract surgery. Or image-guided systems, yeah.
So with the advent of new state-of-art IOLs, premium IOLs, which we all have been using in our practice, one thing we have to ensure is that we are bang on target as far as the axis placement goes, as far as the centration of the IOL goes, or else we'll end up leaving a very, very unsatisfied patient. Now, in case of toric IOLs, one needs to see that our pre-op axis marking is perfect, because we all know that there is a lot of cyclotorsion which occurs, and in some cases it can be as much as 15 degrees from the sitting position into the supine position, and this can almost totally negate the effect of a toric IOL. So this pre-op axis marking traditionally is done with a marker, either a freehand marker or on the slit lamp, and this is done with the patient in the sitting position, but these are all filled with errors. Now, as you can see here, if the slit lamp beam is either above the pupil or below the pupil, doesn't go through the central Purkinje image, you're bound to have a wrong 0-180 marking. At the same time, when you're marking with a pen, very often you have thick markings. And these thick markings, as peer-reviewed literature has also proved, these thick dots can cause variations in the implantation axis of as much as 5 to 7 degrees. The bubble marker also is riddled with the same problems. The only thing, the advantage of a bubble marker is that at least you're keeping the marker in a horizontal position. We have quite a few smartphone apps like the Tor Axis or the Tor Easy, which is being used, but again, one needs to point out that it uses the gyrometer of the smartphone. But in these, the main problem is the surgeon or the person doing these measurements or doing these markings have to have a perfectly steady hand, and a little bit of movement here and there can again cause a variation in the axis. Now again, on the OT table, there are manual markers available. Again, thick dots over here can result in a wrong placement of the IOL, especially a toric IOL. So in today's era where we plan everything, our travels are planned, including our meals are also planned, then I think why not have our cataract surgery totally planned? So the image-guided systems which are available today basically are from the Varion image-guided system and the Callisto from Zeiss. I have no financial interest in any of them. But since I have been using the Varion for more than 5 years, I'll restrict my talk today to the Varion image-guided system. So the Varion image-guided system consists of 3 modules: the data acquisition module, the planning module, and the image-guided map, the OT module, where you have an overlay into your microscope. The data acquisition module images the eye in such a way that it images the scleral vessels, the limbus, as well as the iris. And this creates a unique fingerprint of the eye, which is used for registering and tracking the eye. So even if the eye is moving, even if the patient is moving the eye, the tracking takes place all through the surgery. Reference images here help us to overcome the cyclotorsion of the eye when you go from the supine sitting position to the horizontal position. The keratometry is done by the measurement unit, and this is done. Two things it does is, one, it calculates the spherical power with the help of the 3 infrared LEDs, and this is measured in the central zone of 0.8 to 1.2 millimeters with over 900 corneal reflections. At the same time, the corneal cylindrical power is calculated with the help of these 12 white LEDs in the still position, again in the central 2.8 millimeters zone with 60 corneal reflections. So as you can know, it's a high-tech device. It measures plenty of more points than a routine keratometer. At the end of the measurement, what you get over here is the entire data, which includes the limbus to limbus measurement, the pupillary size, the steep axis, flat axis, and then we have the chance to see whether all these are in the green zone like you can see over there, and then either accept or reject these readings. So what are the advantages of the keratometry when done on the Varion? So this can be used in cases of bad corneas where other keratometry methods are not reliable, like post-operative, post-keratoplasty, pterygium with a corneal scar, or in cases of post-RK. At the same time, with the help of the Varion, you can have 3 different centers which can be measured. That is the center of the limbus, the center of the pupil, and the most important being the center of the visual axis, because that is where the placement, especially of a multifocal IOL, is very, very important. Now this data is then transferred to the planning unit, and in the planning unit you have a chance to compare the various keratometries either by your which you have fed in from your biometer like a Lenstar or IOL Master, and compare the other Varion readings. It also has a chance to select whether you use an optical biometer or an ultrasound biometer. At the same time, you can fashion your incision size, so you can keep changing your incision size and the location in order to reduce the post-operative residual error. So you can keep moving the incision during your planning. So you can keep moving it to get the least astigmatism even if you're not using a toric IOL. At the same time, so the wound construction can be planned. There are a host of inbuilt IOL power formulae which are available and for us to choose. Now the most important thing is the IOL power selection can be done based on the post-op refraction. In our normal routine biometers, what you get is only the spherical equivalent. Here you can know what the approximate post-op refraction would be. So in case you're not using a toric IOL, you're leaving behind a minus cylinder, you can err on the side of a little bit of hyperopia in the spherical power instead of the routine myopia in order to compensate the cylinder in the form of a spherical equivalent. Again, the planning station can be used for post-refractive IOL power calculations, and there are for various ocular conditions it can be used. At the same time, it has got the mode for phakic as well as pseudophakic eyes, and for in the bag or in the sulcus placement. Again, there's a whole list of lenses, and the customization of the A constant is possible over here. So either you can use the company A constant, or by feeding in your post-op data, you can get in your personalized lens constant, which every surgeon can use. SIA optimization, that is a surgically induced astigmatism optimization, for each surgeon, normally we would send all our data to the Warren Hill SIA calculator. But here this can be done on the Varion planning station itself by feeding in your post-op data, and it gives you what is your surgically induced astigmatism. It can be used to plan the number of arcuate incisions you want to make in case of an LRI, the depth of the arcuate incision, and the extent of the arcuate and the placement.
Are transferred from the
The data from the planning station is then transferred through a pen drive into the OT module, which is then creates an overlay into the microscope. So you have an overlay for the incision, you have an overlay for the capsular rhexis. As you can see here now, you can have a plan. Everything is pre-planned before you enter the theater. So your side ports, your main ports, everything is pre-planned, and you can have the exact position of your capsular axis. So you can plan that the capsular axis is bang on the visual axis. You can choose it to either have it on the visual axis or on the pupillary axis, but most of the times we would choose it, and you have a continuous overlay. So you can track and you can vary the size of your capsular axis. So you can have a 5 millimeter or a 5.5 millimeter, whatever you're comfortable with, and then see to it that your capsular axis is almost perfect. Again, you have a toric axis overlay. Now here what is most important is the overlay gives you, the axis placement gives you the entire horizontal line across the whole cornea. When we do the marking with a pen, we are just marked these two ends and we are not having a line across the whole cornea, and this is where the exact placement of the IOL comes into play. Again, it gives you a guide for IOL centration and for finalization of the position of the lens. So this is a small clip. You can see here now, this is the toric marking on the lens. It's a panoptic toric, no financial interest again. And you can have a perfect placement of the lens along the guided axis, and at the same time you can then check for the centration of the lens. So you can, the crosshairs here are showing the exact center of the visual axis which we wanted to do. At the same time, people who are using the Lens 6, the Varion can also be coupled with the Lens 6 and thereby giving better results even for the Lens 6 users. So in conclusion, well, though it is expensive, it is a tool which really helps to take your surgery to a different level. And the accuracy and the perfecting the vision, what we can give it to our patients, especially the premium IOL patients who desire the best, this is something which you can do with the Varion. So I would think that it is definitely not a hype. It is definitely a tool which is useful in today's era. Thank you. I would now call upon Dr. Sujata Mohan. Well, after having done all this, after having done the perfect planning and after having done keratometry in the perfect way, keratometry and the biometry, we still have cases where we don't hit the bullseye, where we have a residual refractive error. So Sujata is going to talk to us on what to do when she doesn't hit the bullseye. We take questions after this, if you don't mind.
Thank you, Dr. Nitin. That was a wonderful talk and really a lot of learning so far. And I hope I hit the bullseye in my talk as well. Okay. Do this. Okay. So I'm going to show you a series of cases. So this was a patient who needed, oh, not come. Oh, okay. So this was a patient who was a 57-year-old female who had immature cataract in both eyes, and she had a pellucid marginal degeneration, as you can see on the. Go on again. I have but I don't have that adapter for that adapter. Came and then went. Okay, try. Try this.
ये उनके लैपटॉप पे अभी यूज किया था ना.
coming? Yeah, that's okay. So this patient had, as you can see, a PMD, and the pre-op refraction was, again, it's gone off. I don't have. No, I don't have. Why is it going off?
Transfer it into their laptop.
I have a lot of videos and all that.
Oh, then it will not.
It will not work, that's why. The main thing is why? What's the problem? I have so many patient talks I've given. You turn this and then you put it again, yeah.
Okay.
Okay, let's hope for them. Because,
इधर तो आ गया नहीं हाँ it's coming
okay,
hopefully
Wait. Lose contact. Either say lose contact.
okay.
एक मिनट
The problem is my problem, is it? Is my laptop? What's it? Huh? Laptop problem, huh? But it's coming, no?
Can you mark a limbal relaxing incision on the virion system?
Totally, just now I presented in 3 halls.
You can, like I showed in one of the slides, you can plan on the planning station. You can plan the
No, but
depth of the
asking you
incision.
why you're
you
not
can
able to
plan
make
the
it.
Site of the incision, and at the same time you can also plan the length of the incision.
Does it
And that also will come as an overlay into your microscope. So it becomes, again, it makes life very simple.
so we don't have to use the Abbott LRI calculator for?
There is an inbuilt LRI calculator in the planning station itself.
So how much have you found your results if you compare before you got this and after you got this? How much has changed? Practically speaking.
I think we are hitting bullseye almost in about 96 to 98% of our patients.
Bullseye, you say within plus 0.1?
6 patients in torics, unaided 6 in almost about 95% of the patients. I'll put it in another way. In the past, my toric usage was only limited to patients who had a cylindrical power more than, say, 1.5 or something. Today, even with a small cylindrical power of 0.6, 0.7, especially with a multifocal IOL, I am confident to convince that patient that go in for a toric because it's going to eliminate their cylindrical power. So that is how I would quantify what my results with the toric are, because though I may not have calculated the exact numbers, but then since I have become more confident, I wouldn't mind convincing this patient to go in for a toric and promising excellent results.
So my question is why we don't have IOLs with a difference of 0.25 diopters?
That's a question we've been asking the trade n number of times. They
and
only claim the problem to be the logistics.
And with minus 0.5, will that be a just illusion to have hit bullseye and hemetropia?
Bang on, I agree
No
with
point, I mean, blaming all these errors in surgery and biometry when
True.
we don't have IOLs with a difference of minus 0.25.
that. Very true.
So is it like we are just talking about maybe which is not there and we are just following some illusion to get an hemetropia 6 by 6?
The only place where we can get them is when we're getting them manufactured in the Indian scenario. There are companies in the Indian market which are manufacturing IOLs. In fact, their box states the
Putting
power
actual
which is
power.
actually
But
available.
most of the times you are not sure even about that actual power also. Even with that actual power also you get a different surprise most
I think
of
that is where
so many
faith
times.
and trust comes in.
Obviously.
So we have
That's
to
what.
believe
That's what.
that the company is doing the right thing.
So would it be fair to say that tough for all the big guys in the world, they say that if you're up to 0.5 and 85%,
0.5 is bullseye, in my opinion.
I would think
0.5 is bullseye.
That's what not we are aiming for. That's what we are
Very
not
difficult-
promising.
very
We are not
difficult to
telling
get
the patient that
hemetropia.
it's
Please
in
understand,
0.5 only.
Even if you have 0.25 diopter power, it's very difficult to get hemetropia in all cases. So what is the gold standard is have within 0.5 you are almost on the bullseye there. So
That's not what we promise to the patient. We don't tell them that you
no,
may have
0.5
0.5 post-op.
see,
We Most of the times. That's what
No, no, you
everyone is
can't
talking.
promise-
It's 6 by 6 unaided.
Please
which is
understand.
not there with minus
No,
0.5.
you're not promising plano. You're not promising, you're promising 6 and 6 vision for these patients. You're not promising plano. Okay, within 0.5, they will 100% they'll have 6 and 6 vision. That is what it's a message which I want to give all of you.
I mean, I think if I may add that I tell all patients, premium, not premium, anyone going for an Indian multifocal or an imported
That's my
multifocal,
black this
that
No, no,
your,
my black.
your dependence on glasses
My
will
adapter,
reduce. I think anyone who promises spectral independence is really brave, because there is that thing about the corneal biomechanics. What about the wound healing? What about my
Lots of
incision
factors.
banega kaise? I might have done 100,000, but I'm not going to necessarily get a perfect incision each time. So I feel that it's safest, and actually it's the truth to tell patients that you may require glasses for 5% of your activities, either for distance, either for near, or for both. That not only keeps you safe, but you're saying it because that actually is the truth. I see a lot of patients who have been promised multifocal lenses, who are walking around after multifocal lenses, not been given the correct correction, with that little correction which would have made them so much better. So if we promise what can realistically be achieved, and what I tell them is, yeah, I'm doing my best, and they can tell you're doing your best, right? Patients can tell that you've taken multiple readings, multiple instruments. But I tell them that it is at the end of the day the machines that are doing the calculation. And we can only do this much, and whatever we are doing is the best. In fact, they get sick of me because I'll send them to another center I've required to get another test done. But beyond that, I think it's not, I don't think this works. They accept this. And I always say, some glasses for either looking at the Netflix subtitles or for reading the newspaper may be required, but you'll be a lot better off. And I think this is more realistic to me. It's more than just a number you're left with. It's a quality of functional vision where he may be left unhappy. And I think patients who pay for multifocal are unlikely to settle for good near.
Subira, leave alone multifocal.
Anything.
I'm sorry, even the unifocal lenses, how many of you are getting plano?
Not even 20-25% of
Yes,
the patients.
that is I think if your majority of the patients are within 0.5, even in a unifocal, then you are there. That's all. Okay, it's very difficult to get plano.
Most of the times our talks is aimed at getting 6 by 6 unaided or plano.
Different from plano.
Plano, yeah.
Please understand, there is a difference between 6 by 6 and 6. And
What you are saying.
Can I say that 6 by 6, 2020 is measured on a Snellen chart, which is black against white, which is abnormal. That is not a normal living condition. Even if you get, how many patients you plan a toric lens, you get a 6/9 plano without glasses, the astigmatism corrected, and he's so damn happy.
Yes.
We got to go beyond because minus cylinder.
Yes, that's what. Yes. So do we really aim for even correction of a smaller cylinder also, 0.5, 0.75? Patients are better off with that cylinder post-op.
If you've got against the rule astigmatism, that means a plus 0.75 and beyond. Even something as small as 0.75 against the rule is correctable by more than one. Sorry.
Yeah, thanks.
Today I'll just go through my presentation very quickly. So again, coming back, you can see this patient has a PMD and a cylinder of 4.5 spectacle, but 6.7 on the pentacam, and this also cylinder showing 7.7 in the topography. So the axial length was calculated, the flat and steep K were also calculated. So we did a customized lens for this patient. We ordered a customized lens from one of the Indian companies so that we could cover the 7 diopter of astigmatism. And post-operatively, she got a -7 cylinder. So she had a -5.5, so -7 cylinder. So what we had to do was, what we had done wrong was, instead of placing the lens 180 degrees, we had placed it along the axis. So these lenses are carrying the cylindrical power. So I had to rotate the lens back into 180 degrees, as you can see. So once we rotated the lens, so these are plate haptic lenses, and since within 2 days we realized what we did wrong, we rotated the lens to this is 180 degrees marking. And it's quite easy to shift these lenses because they are plate haptic. You have to be a little bit careful about not injuring your PC. And once you've rotated that, so the next post surgery we found the patient had a good refractive outcome. She had a -1.5 SIL. So the important plan here is when you have had a refractive surprise like this, repeat all your pre-op tests, IOL master, lens star, topography, pentacam, dilate and check the position of the IOL, redo the, we were breaking our heads and finding what did we do wrong because it was exactly the same, and then we went back and looked at the lens picture. We found that you have to place the 0, 180 degrees and not along the axis. So high incidence of errors and abnormal corneas due to irregular astigmatism. She did have a -1.5 SIL, but she was quite happy. So this is one of the papers which also says that in such cases, what you can do is leave the patient aphakic, go back and do the refraction. They say the intraocular lens power calculation gets better with aphakic refraction methods. The second case is an RK patient who has a +1.5 SIL. She was being very happy. And suddenly now she develops cataract. Now we have to tell her about the problems post-RK because most of these patients have a hyperopic shift and you have to tell them that they can land up in a problem. So this is a conventional lens power calculation using the IOL master and the lens star. You can see I got a +17.5, but using this is a pentacam picture of the patient. And then we use the Barrett's formula. You can see that the maximum is 21. So there's a lot of difference between the calculations. So these calculations are very important. So this patient, we advised her not to go for a toric lens because I told her we may be off mark and you may have a lot of hyperopic shift. So in that case, it's better to avoid it. So the problems in post-PK RK, I'm not showing the video because we are out of time. But the most important thing you have to remember is that these incisions can give way. If you so do an ASOCT to find out the depth of the incisions, and wherever you're placing your incision, just make sure it is between the two marks. So this patient had about 8 radial keratotomy. Sometimes you come patients with 16 radial keratotomies. In these cases, a scleral incision would be preferable. So biometry is a big bugbear, and RK wound gaping and hyperopic shift has to be kept in mind. This again is a patient with a pre-LASIK power of +4. She's been very happy without lenses. Now she's very keen on multifocal lenses. See, look at this map. It shows a clinical keratoconus interpreted. It is actually not keratoconus. It is just a hyperprolate cornea. So when you go do an hyperopic ablation, you get a hyperprolate cornea, which is interpreted by the machine as keratoconus. So you can go ahead as long as the incision is well centered. You can see the ablation is a well-centered ablation. You can go ahead with a multifocal IOL. Again, using the Barrett's formula, and I also did this Barrett's formula on the IOL Master 700 is very accurate. So we also calculated with the Hill RBF formula, and they were very close to each other. So we put a +2.25 lens, and the patient was a very happy patient. So coming to the last case, which is still, so this is, I just wanted to show you this video because this patient had plano 6x6 and suddenly she decided that she wanted to have a multifocal IOL. So we put a multifocal Sulcoflex. It's not working as I just expected. Okay, coming to the multifocal IOLs post-hyperopic classic, you can go ahead with well-centered topography, good IOL master and Barrett's formula, and good counseling. You have to make them understand that you may not hit the bullseye always. So this is a patient, a unique patient, had myopic classic. She was a young patient, only 52. She had -2.5 spherical, and we did the Barrett's formula, we did all the calculation, and she had a 1.3 diopter of astigmatism, didn't want to correct it. So this was a slightly decentered ablation, but she's never used a cylindrical spectacle. So now we did the Barrett's formula calculation and got a 20 diopter lens. And you can see that according to the Barrett's formula, we are supposed to place the lens at 110 degrees. So we placed a IQ toric lens, and you can see the position of the lens post-op. But what happened to her refraction? See, this is what was planned, and you can see beautiful correlation. But post-op, she had a -2 cylinder. She was having -2 spherical pre-op, and she had a -2 cylinder. So the question is, what are we going to do with this patient? We went and did all the other pre-operative tests, repeated it, And we found that the cylinder was exactly what we planned, and it was at 106. You can see we have placed it at 110 degrees. And the only problem in this case we realized was the patient had decentered ablation. So the options in this patient is to go ahead and do a bioptics, that is do a laser. Either it could be a wavefront optimized PRK, you just correct the spherical power, or if you want to do slightly more, then you can go for a contour vision, which is a topo-guided PRK, which will correct the cylinder but more effectively as well as normalize the cornea. So that she's waiting for this. So refractive surprises can happen after post-LASIK, PRK, ectatic corneas, vitrectomy, silicone oil. So newer formulas, Barrett's formula and Hill RBF and topography, good topography has helped us achieve nearly good, very good results. We may not claim that we get 6x6 in all cases, but the refractive surprises have definitely come down. And we're hitting the bullseye now almost every time. Thank you, and thanks for giving me the opportunity to present.
Thank you, Dr. Sujata. I think in the paucity of time, since the next session, people are already over here, I think we'll have to wind up this session. But in case people have questions for Dr. Sujata, for any one of us, I think we'll be right outside the hall for the next few minutes, so you can talk personally about it. Thank you. And I thank all my co-instructors for having participated and making this a great course. Thank you.